Hello, everyone, and welcome to this webinar. I'm Dr. Jason Pang, and thank you to Nutripath for this invitation to speak. I'm just going to share the presentation. So today we're going to talk about oral microbiome testing and how it relates to oral health and systemic health, how we can use the testing to really optimize how we treat the mouth and how it can affect the rest of the body. So some disclosures before I start. I'm a practicing dentist in Sydney. I lecture on various topics. I have a dual master's in laser dentistry, and I teach a master's course overseas as well. I'm the Australian trainer for various lasers. I'm a member of the American Academy of Oral Systemic Health and a clinical advisor on the Lichen protocol, which you'll hear a little bit about today. But as a dentist, the most common things that I treat are dental caries and periodontal disease. Dental caries, tooth decay, which of course causes pain, infection, loss of teeth, and that affects almost half of the world. And periodontal disease, which in very severe cases can cause loss of teeth, but certainly tooth movement, pain, and it can affect more than 50% of the world globally. The commonality between these two problems is the biofilm. So if we use a special disclosing dye, we can actually see where the biofilm is on the teeth. Where it's dark blue is where it's very mature biofilm, has been there for a minimum of 24 hours. And you can see changes to the pH when it goes a light blue. And where it's pink is where it's new biofilm. So definitely a biofilm problem, but it's not something that's exclusive to the teeth. It also is on the tongue, the cheeks, the tonsils, and can be a reason for problems like halitosis, oral lichen planus, and potentially other cancers of the mouth and the gastrointestinal system. So in Australia, being a first world country, really not doing that well compared to some other countries, because still, this report shows 43% of kids are still having tooth decay. More than 50% of our elderly are having gum disease, and there's far too many cases of oral cancers and other cancers. So the oral microbiome typically has around about 700, closer to 800 species now that can be found. Each individual usually has around 200 to 300 species within the mouth, but that can vary. And it is the second most diverse community after the gut. So it plays a really, really important part in our overall health. And using systems like DNA PCR or other ones like shotgun metagenome sequencing, we can look at the bacteria that's in the mouth and determine if it's going to be a problem for the mouth. So most everyone has around about 20 billion bacteria within the mouth, which increases about fivefold after 24 hours. Each milliliter of saliva has 100 million bacteria, and we swallow a liter a day. So we really do swallow about 100 billion bacteria a day, which is a lot. And that's why it can affect other organ systems and can get into our bloodstream and so on. So how does the biofilm form? Well, a it forms because we have free-floating bacteria around the mouth, which we eat in the food and drink. And then as that adheres to surfaces, it matures, it thickens, it forms this matrix around it to protect itself, becomes thicker and dysbiotic before it starts to break off. And then that's how it can travel to other parts of the mouth, other parts of the body. So when it happens around the teeth, we have uh, reaction. We have the an immune system reaction, and if especially if it's a chronic inflammation, then we can have a prolonged immune response. That's when we have activation then of cytokines like IL-6, TNF alpha, matrix metalloproteinases, which start to then damage the oral tissues, and that's where we can have problems like uh, periodontal pocketing, uh, inflammation, and bone loss. And then there's other things that will affect it, like your diet, stress, smoking, poor sleep, insufficient or professional cleaning, substance abuse. And then these can lead to two-way relationships, which we know of, like obesity, diabetes, rheumatoid arthritis, non-alcoholic fatty liver disease, where patients have too much sugar and too much triglycerides. And then you can have causative or perhaps comorbid inflammatory conditions like cardiovascular disease, inflammatory bowel disease, neurodegenerative conditions, Alzheimer's, Parkinson's, and then pregnancy issues as well. So they have identified certain bacteria that are related to conditions. So in the case of periodontal disease, we have the red complex bacteria, which are very, very highly associated. So Porphyromonas gingivalis, Treponema denticola, Tenorella forsythia. These are part of that red complex. And then with caries, it can be strep mutans, it can be some of the other lactobacilli or other non-mutans streptococci. There's other things like Aggregatibacter, which we know as AA, and that can be involved with diabetes. We have relationships with various gastrointestinal cancers, and in those cases, particularly P. gingivalis again, AA, but it also can be Fusobacterium nucleatum. We've seen it with rheumatoid arthritis, various other bacteria, cystic fibrosis, cardiovascular disease. We know again, P. gingivalis seems to be one of the main culprits. And then with Alzheimer's disease, both the spirochetes and P. gingivalis seem to be again highly associated. And this is very, very topical because even just last week, there's some news articles which came out which showed that improving your oral hygiene by flossing at least once a week could improve your risk of having stroke. This report showed that there was a 12% lower risk of atrial fibrillation, 22% lower risk of ischemic stroke, 44% lower risk of cardioembolic stroke. As a result, and let's just read this bit down here, flossing helps prevent the buildup of bacteria that can cause inflammation in the body and harm the heart. But it really depends on what kind of bacteria is on the teeth and in the mouth, because you can have extremely heavy biofilms, like on the top left-hand picture, but you can see it does not cause inflammation, but it still travels around to the rest of the body. And then you have on the lower left, the minimal biofilm, or perhaps underneath the gingiva of the biofilm, and you can't see it. But when you do a clean, you can see heavy bleeding. So really, it's important to understand that clean does not always equal to healthy, and it depends on the type of bacteria that are circulating and growing as to what we need to do. So in a case here where we have a lot of biofilm, we have inflamed gum, then if we look and use a technique of using live biofilm screening with a microscope, we can actually see the types of bacteria that are there. And the more active it is, we know the more problems that you're going to have. So here's an example of what it should be like. This is a eubiotic biofilm where there isn't a lot of bacteria around. There's not a lot of activity, no white blood cells moving around. So very, very still, as opposed to a dysbiotic biofilm, which has white blood cells, a lot of movement. You can see the spirochetes. You can even see there's a parasite here on the lower right-hand side. And that can lead to many types of problems. And it's this kind of of visualization is very helpful to the patient. It tells them why they need to brush and gives them some motivation to keep going. And we know that it can cause problems like halitosis with volatile sulfur compounds in this patient that's not cleaning very well, that has a lot of bleeding, a lot of calculus. With this patient that has dental caries, and you can see the lesion there, and that's where we try and remove the bacteria from that area of the teeth. We can use it with the laser and ablate those areas so that bacteria don't continue to stay around that part of the tooth. And then there's cases of periodontal disease where you have and recession and bleeding, and this kind of bacteria that can look like this with lots of spirochetes. Or if you look at a different part of a slide, this patient actually had a parasite called a trichomonad, and you can follow that around. So it's very important to find out exactly what kind of bacteria is hanging around in the person's mouth. This is an endodontic lesion, so a root canal, and we can time lapse the recording, and we can see the amoeba moving around the slide. Quite confronting for patients at times. It wasn't until I was teaching overseas that I found that a lot of the universities overseas are quite amenable to using these technologies, testing the biofilm, looking at microscope samples, using dental lasers, using antibiotics and other mouth rinses to try and manage the oral biofilm. So here's a case we started a few years ago, and this was one of the first cases where I would use oral microbiome testing. So the patient lost a tooth from periodontal disease, had a bone graft, and you can see on the right-hand side, the patient isn't brushing particularly well. So what we did was we sampled their oral bacteria, found that had a moderate bacterial load, fair amount of motility, and some spirochetes. And so we wanted to improve that before we place an implant for the patient to see if and help to prevent peri-implant problems. So once the implant was placed, and then we were able to have a look at the oral biofilm, we could see what kind of activity was there. But again, it doesn't give us enough information about what type of bacteria is there and whether or not it's the type that's likely to cause complications. But here's a test that we did first out of the United States, and it gives a range of dental bacteria. You can see that TF here and TD, these are the red complex. Tenarella forsythia and Treponema denticola, they were below threshold, so less likely to give complications, but we do not ideally want to see any of those bacteria around. And so the others were below threshold as well. So that was a good start. Then we looked at periodontal disease where patients already had bone loss, and this one required a tooth to be taken out. Looking at the mouth, we can see a lot of biofilm, poor cleaning. And when we look at the biofilm, we can see it starts off with a very, very high bacterial load, lots of movement when spirochetes. And about a year later, the bacterial load is very, very much less. And so that gives us an indicator that the patient's doing quite well. But we wanted to really measure and see if there was if this was really the case, and then we really made an improvement to the bacteria. And so this kind of test allowed us to show, yes, we can definitely see the effects in both the biofilm and in the live screening. So then we started to transition to using the Nutripath testing. And here's a case we started in 22, and you can see a very, very busy biofilm there. And then over the subsequent years where we've treated the patient. The patient has recovered from tonsillar cancer, had various treatments for that, and then we're able to really reduce the amount of bacteria that's in the mouth. So the two red complex over here, TF and TD, you can see that that's these two here. So both substantially reduced. The orange complex, Prevotella intermedia, Parvomonas, these ones are all reduced as well. FN is reduced as well. So very, very good feedback on how an improvement to the oral microbiome can really impact the patient's health and hopefully prevent a second round of tonsillar cancer. Here's a patient that has oral mucositis as a result of cancer therapy from breast cancer. You can see the dysbiosis, the amount of bacteria that's in the mouth, and I've looked at sped up the sample so that you can see the movement of the amoeba that's in her sample there. And then when we do the Nutripath testing, we now have the ability to also look at these opportunistic, pathogenic, but also then fungi and what we consider commensal or normal flora on this lower right-hand side, sort of here. So unfortunately, because this patient had metastatic breast cancer, the oncologist wanted me to test particularly for Fusobacterium nucleatum because it acts as a bridge to some of the nastier bacteria. And when Fusobacterium nucleatum is present in on the cancer cells, it also makes them more aggressive and less successful cancer treatment. So here, because this patient has been quite regular with us, 15 months later after we first assessed her, we're able to see that there was quite a number of reduction in all of the bacteria, both opportunistic and pathogenic. But the two things that did stand out was that the candida albicans, so the fungal infection was high, so she needs to be treated for that because that can impact her cancer treatment. But the one that we were worried about, Fusobacterium nucleatum, was substantially reduced, and we will continue to try and reduce that bacteria. So let's apply it to now to a periodontal case. So this is a patient that came to us with bone loss and periodontal disease. You can see that the cleaning was reasonable, but they still had bleeding after cleaning. When you look at their biofilm, you can see that it's quite dysbiotic. There's amoeba spirochetes there compared to at their 14-month review, which had a lot less. And when we looked at them, we could see that there has been improvement, even despite the brushing not seeming so good. There wasn't any bleeding after cleaning, which was very, very optimistic. And so we could see that the pocketing that we recorded at the beginning of the treatment, all of those green areas showed improvement in the pocket depths, so the gum pocketing around the teeth. However, we were a little bit surprised to see that there have been some various increases in bacteria. So overall, while there was 6 bacteria that improved, there were 3 that were worse. In particular, E. faecalis here and Prevotella. And then we did some additional imaging and found out that there were some more problems. So this patient had continued to have severe decay, an additional root canal that needed to be doing, and root canals on the other side as well. And that's because they weren't able to return 3 monthly for their hygiene appointments. They could only turn up about 11 months later. So that all of these lesions progressed and were made worse. And you can see how the bacteria deteriorated over time. Here's a case where the patient was generally well, but had this inflammatory stomach pain, and she had the stomach pain whenever her gums would be inflamed as well. So doing the bacterial testing, we found that PG, CG, PI were all above threshold, but she also had some amoeba. So the dental treatment was dental hygiene every 3 months with guided biofilm therapy, which is an air polishing technique specifically to remove biofilm. And then we needed to improve her oral hygiene. So electric toothbrush, she used ozonated water to rinse with, cleaning in between the teeth, and tongue scraping. So you can see overall, uh, she doesn't have very many problems dentally. She's cleaning reasonably well on the outside surfaces of her teeth. But when we look at on the palatal side, we can see that she really isn't brushing that well on the inside, and that's what makes all the difference. On the lower, you can see when that buildup is too thick, it forms calculus, and then when we removed it, there's a lot of bleeding. So compared to the beginning with her presentation and 3 months, you can see a significant difference in how it presents. And if we have a look over here on the lower left-hand side, you can see this is an amoeba slowly crawling across the screen. And unfortunately, the Nutripath testing at the moment doesn't test for oral amoeba. But you can see, despite that, we can see, CG, how it's high, PI, and PG as well. So all of these were high, and that's what we need to get down. So testing 3 months later, we can see that really all of those numbers went into the green, so in below threshold, and we were quite happy with that. Everything improved in the patient, and she had no more problems. Fortunately, we wanted to see her an additional 3 months later, but she traveled and moved to Indonesia. She no longer was able to rinse with the ozone, and her brushing really hadn't improved that much compared to at the start. Um, so that infrequent cleaning really meant that she was behind the 8 ball again. And when we look at the oral biofilm, we can see that the numbers had jumped up quite a lot. So in fact, rather than getting better, there's six of them were worse, and only 3 of them were better. But even from that, she found that she had no bleeding during brushing or during the hygiene appointments. Her mouth felt less full. She had one gambus episode in the first 3 months when she was doing well, but that resolved spontaneously. And then she did have another episode, just before she was going to come back to us, and in the 6 months later. And then she did have another case of stomach pain in that preceding 6 months. So here's in a case of what we can consider an autoimmune condition, Sjogren's syndrome, and systemic lupus erythematosus. So the patient feels a lack of saliva. And so when we did the Nutripath testing, we found severe bacterial dysbiosis with lots of spirochetes, high in the red complex, and fungus as well. So improved her oral hygiene and came up with a treatment plan for cleaning. And so the patient did much better with the cleaning. So all of that is going to improve. And then what we saw is that 7 of the bacteria improved, 2 were the same, 1 was worse. But most importantly, with all of those improvements, the patient found that she had more saliva, less bleeding, and no more of those acute lupus lesions, those painful lesions around the mouth. So we're very, very happy with the result. Here's a case of leukoplakia with atrophic lichen planus that was diagnosed by a specialist, and the patient had pain on the left side of her tongue and gums for many, many months. The testing showed that she had high numbers of orange complex and P. gingivalis. So we did some laser treatment to help with the lesions and improved her oral hygiene. You can see the very keratinized, thick roughness of the tongue, although no painful lesions right there. But when you look at the numbers, see Campylobacter very, very high, Prevotella very, very high, Porphyromonas gingivalis also very, very high. And that happens because the patient really, wasn't brushing very well. Even at 3 months, still need a lot of room for improvement, still bleeding after we did the clean, but still that improvement in the microbiome meant that her tongue felt much, much better and no longer was keratinized, didn't have the thickness or painful lesions. So when we look at her improvement after 3 months, we can see that all of her numbers had reduced by about half. So 5 of them improved. But still at this point, very, very busy live bacteria screening. Very, very full. However, complete change. We did get her to start using an electric toothbrush, which she wasn't using at that point. So her cleaning is much, much better. And no more bleeding. And then when we test it again, you can see really everything's normalized. 6 of the numbers had improved, and there was only 1 that had gotten slightly worse. And that matches up with the changes to the bacterial screening that we can see. So very, very happy with that result. But for her, the tongues and the gums were no longer painful. Her gums were not bleeding when she brushed them. And the tongue didn't feel keratinized or stiff, which is the main problem that she was complaining of. And here's a case where a patient was about to undergo some heart surgery, but we found some endodontic lesions, so she needed some root canal, and there was some periodontal pocketing around some of her back teeth. And when we did a cone beam CT, we found that the pocketing went all the way down into and to where the inferior alveolar nerve and blood vessels are. So there's a direct communication from the mouth into the bloodstream. And so there's the possibility that all the bacteria that she has, which includes these high numbers of P. gingivalis, which is highly associated with cardiovascular disease, that can go directly into the bloodstream. And we worry about this because I've had a patient that had multiple heart attacks, and when we assessed them, found out that there were 4 root canals that were untreated and needed attention. So for our patients, this is what we do if they are referred to us by a specialist, or if the patient would like to share their physician's details. We write a report to the physician about what is going on in the mouth, the relationship between the microbiome and the testing that we do, and the type of treatment that we're going to continue with until she gets seen by the specialist. So to finish up, what oral microbiome testing tells us is what bacteria and fungus are present, whether they're opportunistic or pathogenic, and in what quantities in colony forming units, so we have an exact measurement, and whether or not it's above what we consider a threshold level that's likely to cause problems. We can see if the patient's home care regime is good enough, whether they have been doing what they say they've been doing, or if they need to have additional measures such as interproximal cleaning or or tongue scraping, then we can see if our therapy that we've advised for them or done for them has caused a bacterial or fungal shift. We can see both the type of bacteria that's or microbes that are present and in what quantity. And then it lets us to decide if additional treatment is necessary or perhaps if it's not something that we can do and it needs the help of a specialist. And the new testing that Nutripath is coming up with is whole genome, whole metagenome shotgun sequencing, which allows us to look at the bacterial community as a whole, how they function and how they interact with the body, as opposed to looking at individual bacteria, which is helpful but doesn't give the complete picture. And hopefully we can look at some of these changes and then but we definitely can see the changes to the patient's mouth and to the patient's overall health. So I'll give this copy of this paper that I wrote to Nutripath, and you can ask them to download it from them just on say peri-implant complications. And if you're a member of Facebook, I'd say join us on Hygiene Hackers, and you'll be able to see some of the posts that we put up of live biofilm screening and things related to bacterial load and oral health. So I hope that gives a good overview of how we can use the DNA PCR testing, look at the bacteria that's in the mouth, see how we can change those numbers and really impact the patient's dental health, but hopefully their overall and systemic health as well. And you can, if you click on the QR code to follow us on the Larkin protocol, so you can look at the live biofilm screening, and you can contact me with the QR code on the lower right-hand side. So I'll just stop the share. So thank you very much for your time, and I hope you enjoyed that. See you.